Thank you very much, everybody, for joining. Today, as I was telling Dr. Parthiv Mehta, is our 10th anniversary for this webinar series. And today we have a wonderful program. The first one is going to be moderated by Dr. Parthiv Mehta on monitoring and sustaining breathing during and after COVID-19. And the second part is by Dr. Amish Vora on D-dimers, anticoagulants, and COVID-19. For our faculty, we have Dr. Prashant Mehta as expert panelist, Dr. Divetia, who's ICU and anesthetist from Tata Hospital, Dr. Akhil Kapoor from Lucknow, Dr. Udit Maheshwari from Mumbai, and Mr. Apurva Gandhi, who is a person who was a COVID patient, and he actually benefited from all the breathing exercises and breathing taught to him by Dr. Parthiv Mehta. So, Parthiv bhai, over to you.
Yes, thank you so much. First of all, Purvish bhai, for making me to come into this group and getting connected. And this is an opportunity wherein probably we will be trying to bring in some of the topic which probably have been thought of to be not so much importance. But in our routine practice, in day-to-day practice, we have felt that there is a possibility of looking after such points which can help us to make the outcomes better. So what I'm trying to do now is present a small presentation which is targeted towards drawing our attention to the point of maintaining and sustaining breathing during COVID days. I hope what I'm presenting is now getting visible here on the screen.
Yes.
I have put in two cartoons here. Both have very typical importance remaining there. People like us who are not regular on exercise, when they come across such a pathology, which makes them to breathe so hard, so harsh, ongoing for longer days, there is always going to be a possibility of not having able to either maintain or sustain their breathing efforts. And when we talk of breathing, it is not simply inhalation and exhalation, but it is also to generate sufficient amount of volumes in terms of inspiratory power and exhalation that makes proper gas exchange to happen, to bring in oxygen, to eliminate carbon dioxide, and try to give our body a sufficient fresh environment which is able to sustain the stress related to the disease. And now we are talking of COVID. And especially when the patients are in the age group, which are senior citizens or those who are having various other parallel pathologies, this importance is being felt by every clinician who is day in and out looking after such patients. We all know about the lung. I mean, there is hardly anything to share amongst the august audience which is here and the specialists who are there with us. But the important aspect of this particular lung is this is a unique organ which has a huge surface area which has been folded. 300 million alveoli, and then when it is coming on a square meter area like a tennis court, it has been folded and it has been placed in a thoracic cage. The part of importance here to understand is that the thoracic cage needs to move well to allow that air to come in and gas exchanges to happen and all the other functions of respiratory system to come up. The problem here is this particular lung, which is a respiratory system, is 24/7 exposed to environment, and that too in country like India, wherein we have pollution at the peak of it, and there are a lot of other infective organisms which are always flying. And now, though we are in 1.5 years of COVID, still people not putting on mask and passing on infection, that also is some of the concern. So while putting in all these, the problem is that when COVID is setting into such a given background environment, no reason that we should not believe that we have good number of morbidity and we are not quoting unquoted mortalities here also. The reason I'm trying to put forward is that when a lung gets affected in this background with COVID, obviously we have to look forward to many aspects into maintaining respiration from the earliest entry of this particular organism into respiratory tract. The nasal cavity, which holds most of the pollutants, most of the primary pathogens when they are in a larger droplet formulation, and they probably are being taken care of then and there only. And then it passes through the respiratory tract from trachea into the lung, and then the functioning unit of lung, which I'm presenting here, which has a mesh of blood vessels which is surrounding an air cell, which is alveolus, and the alveolar capillary interface, which is playing a major role when we talk of the pathology, pathogenesis, and the morbidity and mortality associated with very severe COVID cases, because that particular interface has been found to be really difficult to manage with many of us, those who have been dealing with it. Particularly, this picture has an importance which depicts specific position of a lung or situation of a lung, may it be in a morbidly obese person, or may it be somebody having chronic respiratory diseases, or somebody who's a normal and naturally built person. And the reason we have been putting here is the line which is dotted, which is talking about the diaphragm. Now, the lung is only organ which cannot function on its own to its main vital function, that is inspiration and expiration. It needs the support of diaphragm, that's a muscle. It needs the support of the thoracic muscles. It needs the support of the neck muscles. It needs the support of the neck as a particular air entry point. Heart doesn't need anybody else except for the cardiac muscles. Kidneys do not need anything else except for blood flowing into it. Brain does function on its own. It doesn't need anything to expand and collapse. It is only the respiratory system, which is a very vital system, but it still needs an apparatus to function. And that is the reason when an organism attacks onto this particular apparatus requiring system, there are a lot of mechanics which are getting affected. And that is the reason it becomes very difficult to manage with such affected mechanics, collapsed alveoli, the thickened air walls, the thoracic cage, which probably has lost its compliance, respiratory circulation, which is getting affected when we are going to have our next topic with Amish Bhai about D-dimers and circulatory problems. Cardia itself being affected. There's a unique jugalbandi between the lung and the heart. With every one respiration, heart beats 4 times. So if I'm breathing 25 times, my heart has to beat 100 times. And that too in a morbidly obese post-CABG or IHD patient, or a diabetic is constantly having chronic diabetic myopathy or neuropathies and cardiac problems, they all have this problem exaggerated suddenly coming up on the surface. And it is added on by the infection. The reason I'm narrating all this here is I'm just making all of us to visualize what happens to a COVID lung, what happens to a COVID patient, what happens to the respiration, what huge load suddenly it comes up. The reason is that it is a sudden infiltration, it is sudden pathogenesis, and it is sudden alteration of that homeostasis, which makes the patients who are getting sick more sicker, and the sicker patients to go to the sickness which requires more care. So now directly jumping onto, because I'm going to take only 10-12 minutes to put it on, then we are going to have a panel discussion. So when I am having a COVID, what is it that is going to be helping me in my earlier days of COVID, and what is it being practiced by most of the institutions? Hydration of airway is a must thing. We have been in the early eras where nebulization and aerosol formation and spread of COVID was a big issue, but hydrating airways with warm water or steam inhalation has never been an issue. Dry secretions, dried out airways, that has been a bigger issue in the COVID patients that has been seen. So mucolysis, postural drainage, there are flutter devices, there's a waste which has been used in the Western world. We have also been using in critical ill patients, those who go to the level of retained secretions when they have a mucolysis which is ventilating. And then it comes a mismatch in the ventilation and perfusion. We know that 60% or beyond, our respiratory component is on the posterior and in the lower part, and the back and the bottom. And we all lie down flat, or we always are in the supine position. There is a huge physiological plus pathological ventilation perfusion mismatch which is happening. The moment we make them too prone, the perfusion matching with ventilation happens, and that has been found to be a very effective strategy. We all know it about. The thoracic muscle strengthening, which is very important to start from earlier days of COVID, probably that has been something which requires to be practiced. In most of the places now, physios have started going in. Early area physios were not entering. Now they have started entering. They have started putting the patients who are all controlled under normal oxygenation, saturations not dropping. and then trying to help them out. But the factors which are affecting breathing are this many, wherein I'm sure Dr. Divetia is going to put us more insight with his expertise and his in-depth knowledge about all these factors. These factors are the one which is making sustaining respiration as a difficulty. High oxygen demand, either it is a tissue consumption or fever itself. Respiratory rate, which is going higher and higher. The higher respiratory rate requires higher oxygen consumption by the respiratory muscles itself. And in case if the patient is having subclinical metabolic acidosis, the bicarb start dropping, a patient having CKD or early CKD or probably a diabetic neuronephropathy, and bicarb start dropping to 18, 20, 22, and patient is trying to compensate with hyperventilation, trying to maintain their pH. Very common paradox which has been seen. Anxiety and fear makes them to have a very high hyperventilation out of it. That adds on to the trouble. Airway dynamics change, there is a spasm, there is edema, parenchymal factors, vascular factors, obviously we are going to take it further, metabolic derangements, and nutritional status. This is a huge area which requires to be worked out about the protein calorie deficit. People don't tend to it when they go to a hospital, or people don't to get into a proper nutrition, and suddenly we find that people lose weight, people lose calorie, people get into fatigue, and then we try to put them into a support mechanism. So the idea would be, what can we do that reduces work of breathing? Can be reduced by metabolic balance, bronchodilation, hydration of airways, anxiolytic, which has been worked out very well to reduce anxiety-induced tachypneas. Oxygenation can be done from any flow which works out in a patient. We are not going to get into the depth of what oxygenation flow and how to use it. People have used PEEP valve to keep the alveoli open, and that has worked out in a few patients. If at all it doesn't work out, we go to the level of putting in a pressure support device, which is a BiPAP. And many times patients are required to be ventilated, and tracheostomy works out to be a tool on reducing work of breathing on the ventilated patients so that we can wean them off early, or we can provide them a pressure support for longer number of days, which has now become a very common thing. People have been in the need of 2 to 3 weeks of minimum non-invasive pressure support, or even when ventilated, for weaning off 3 to 4 weeks of pressure support. The area to work out, probably what we have felt, is sustaining muscle strength. When we want to wean off the patient, we want to give the patient back the breathing. The strengthening devices and the anabolics, which has worked out very well. Anabolic is probably a forgotten steroid, that is what has been named, nandrolone and any other supportives. There are very few number of papers, and whenever we reach to the literature, there is always not very favorable, but some sort of input which talks about, yes, can be used. Larger number of studies are required to be done, and probably nobody has yet done it because that has never been an area of in-depth understanding. But yes, it has worked out in the patients who are on rehabilitation, those who are on weaning off, or those who are on a chronic morbidity. And when we talk of onco group, probably they would be the right people to talk about chronic catabolic stress and nutritional supplements and anabolics and its usage. The reason I'm putting in here is that the patients who are on second week onwards, on constant oxygen requirement, on constant pressure support requirement, as a part of institutional protocol, we are putting in anabolic usage, and it has worked out in a favorable outcome in many of our patients. And this talks about the whole, total gamut of the cascade, which takes through the respiratory muscle weakness and respiratory muscle atrophy on a longer run in such patients. And this is what is probably we would be trying to work out on various modality of treatment. We were also talking about some immune modulators. Probably that would be the time which can work out in such cases or not, that comes out. Unfortunately, this all comes to our mind when we have missed the buses in most of the cases. When we come into some consultation with some other patients being kept somewhere, probably it happens that yes, this could have been done or this could have been implemented. So when this group is gathering together, it would be good to have a panel discussion on putting on the points which has worked out to be probably of a point of importance in such patients when we are dealing with. And the most important part, which probably is being the post-COVID evaluation. Dr. Divetia sir would also be agreeing with us that when the patient goes home, it is very important to understand the cardiorespiratory status of that patient, having had gone through this particular, you can say, as an accident or a mishap. We have to give them back what is required to be achieved during post-COVID period. And once we evaluate the pulmonary function test, we do radiological diagnostics. I am personally of an opinion that doing a CT scan on 6th or 10th week, how far does it give a more insight is a question to be debated, but we personally use is only chest X-ray and try to correlate with clinical findings with echo, with ECG and pulmonary function testing, so that what level of rehab or what level of support a patient requires to be given. And then they are being made to run through all various exercises. Every team has their physio teams and every team has their own protocols, which has been followed. But following such protocols, even from earlier days of COVID admission or COVID home care, and then taking them through further as they strengthen their vitality, it has really worked out to be well in most of our patients or the patients who have been treated by many of our teams all over the country, all over the world. The reason I'm putting this forward is that we are blessed to have a team of people who have been helping us out to get through all these treatment modalities. And that's the reason I've been able to spare this time with all of you. Thank you so much, Purvish Bhai, for giving me this opportunity to open up with this. And now I'm trying to open it to the discussion, to the panelists, and requiring or inviting their comments onto this particular topic. Thank you so much.
So let's start with Dr. Divetia. Gigi, are you there? Unmute yourself, please. Or if he's not there, maybe we can start with Apurva. Apurva, please share your experience of breathing issues. Oh, Gigi is back.
Yeah. So,
am I audible? Hello, am I audible?
Yes, Apurva, please go ahead.
Okay. So, Dr. Parthiv Mehta was my doctor, and my COVID was quite moderate. But after I met him, he told me that, look, you build up your exercises on 25% every week. And along with exercise, he also talked to me about the breathing patterns which I should, go through. So I told him I do the pranayam, and what I found was that it was not just the pranayam couple of times a day which we do, but conscious nasal breathing. We tend to do a lot of mouth breathing. The conscious nasal breathing also helped me considerably after that. It's a normal breathing, no pressurized breathing which need to be done. Well, it's just very, very consciously nasal breathing needs to be done. So what I followed up with that was also something called as a nitric oxide dump. That's a 4-minute exercise, high HIIT, which has to be done very slowly initially because you're recovering. You have your muscle weakness and you need your muscles to actually come back. But it's a 4-minute exercise. You can do it 3 times a day. Once that nitric oxide dump goes through, I mean, you are all doctors out here, so I can talk a little technical about it. From the innermost wall of the blood vessel, the nitric oxide will move to the smooth muscle, the second layer. As a result, the nutrition and throughout the body will continues. Now you have to regenerate this nitric oxide again. Allow to
I think we are losing Apurva.
Within 4 weeks, I was totally okay. My physical, what happened?
Mr. Apurva, your network is a little low. That's why I just stopped your video. You can continue talking, sir.
Okay, fine. So as a result, it just took me about 4 weeks. But of course, I was a moderate COVID patient. So for patients who are, who need oxygen and other things, I'm sure Dr. Mehta can give you a better idea. But exercise is must because it is everybody, many of my friends and others who were affected, they keep on complaining even after 2 months that we are still very weak. So you have to bring back your muscles in some form. And this cycle of breathing and exercising actually is very, very important post-COVID.
Thanks very much, Apurva. We'll now move on to Dr. Divetia. Chiki, go ahead.
Yeah, thanks. Thank you, Dr. Parthiv Mehta. That was a very nice presentation. And I think he highlighted things that are not very commonly sort of touched upon. when we care for patients with COVID. And I think one, of course, prone position is very important, and awake proning and self proning, even when patients are on oxygen or even non-invasive ventilation or BiPAP, I think it makes a significant difference to oxygenation, and it gives time for the patient to recover and avoid ventilation in many patients. I think one very important point he touched on, two important points he touched on, was the oxygen consumption. And when patients are febrile and the lungs are not working well, then even a slight increase in oxygen consumption, the lungs find it difficult to reoxygenate the blood well. So high fever, anxiety, and patients are terribly anxious with COVID. Because they can't see their family. There's no one to counsel them. Doctors and nurses tend to stay away for most of the time. So it's a real problem. And the little bit of movement produces a drop in saturation, and people panic and they say, oh, now we need ventilation and BiPAP. But very often, if you just talk to them, say, we can't give them heavy sedation, but even if you just tell them that they're okay and give them time to settle down, they often sort of, come back to a reasonable saturation. And muscle training, I think, is very important. All spirometry, the respiratory muscles as well as non-respiratory muscles, because patients are lying in bed for such a long time and for so many days that eventually their respiratory muscles become weak, and their limb muscles become weak, and they can't stand and they can't sit properly. And you really need to work on all these things as soon as the patient is, a little better and out of the immediate acute phase. And if patients are moderately ill or mildly ill, they must work on even static exercises while in bed. And, I think it's very, very important. And I think these things are not commonly done, and they may contribute to the muscle weakness and the fatigue and the respiratory insufficiency, which may persist even after the patient has sort of recovered from the acute phase of illness. So I think as we see more chronic and long COVIDs, this sort of thing is going to become very important, both in hopefully preventing and definitely when we are treating the longer sequelae of COVID.
Excellent. Dr. Akhil, I know that you have to leave for another webinar in a short while. So we'll take your comments right now. Dr. Akhil Kapoor.
Yes, sir. So as the sir has also highlighted that there is a very important component of anxiety in the patients. Whenever there is some drop in saturation, there are some multiple sounds, there is beeping of the monitors, the patient gets afraid a lot. So it is really very, very important to counsel the patients, counseling that they are okay and they are stable, and there is no need to worry. Something like that, that is very important. We have also seen various videos getting forwarded that human touch is important. So there is a very important concept of psychological counseling plus giving hope to the patient, which is really important to give the positive outcomes. It is not only the drugs, not only the best possible machines, it is the human touch which is very, very important to get the best possible outcomes. Thank you.
Wonderful. Thank you very much. We have Dr. Khilnani. Sir, can we take your opinion on how important is breathing and what do you recommend for our patients?
I requested Amish that I'll be an audience today and not participate because I was not sure about the timing, but thank you very much for. I missed out on the presentation of Dr. Parthiv. I'm sorry about it. There are two things which come to my mind when we talk about physical activity. One is because of the disease. And there was a study which was done in Italy when people were asked after a month of their recovery from COVID. Only 16% of the people said that we are feeling perfectly all right. The commonest symptom was fatigue. And that, to my mind, continues for months. And from SARS-1 outbreak, 3 years after the SARS, 40% of people had complained of fatigue. So fatigue is something, and the commonest this thing is that they don't feel like doing anything. At the end of the day, they just want to relax and just want to lie down. There are two aspects of it that I would like to highlight. One is that muscle weakness, which is because of the steroids mainly. And steroid myopathy is extremely common, and steroids have been abused for mucormycosis and all those things we talk about. But to my mind, the muscle weakness. The second thing is critical illness neuropathy, which is not, we all intensivists recognize in the ICU. And in sepsis, 50% of the people get critical illness neuropathy by 7th day of the illness. So there's no reason why it is not happening in COVID also. So that is one thing. The third part is actually involvement of the lung. That is parenchymal involvement of lung. And we know that the pneumonia is followed by the fibrosis. Although less than 5% of the patient will have residual fibrosis, but their lung capacity is definitely diminished for a few months' time. We don't have data on that. My take is that about the exercise is that some people start exercising in the first week of their mild COVID illness. That should not be done. As a respiratory physician, we know that during the acute illness of any viral or bacterial illness, any amount of deep breathing exercise could be detrimental. So that should be refrained from. And other thing is that this exercise should be started only at the time of after you are sure that you have recovered. Third thing I would like to say that we all have seen a lot of pneumothoraces and pneumomediastinum. Even in patients who are not on positive pressure ventilation, there's actually unprecedented incidence of pneumothoraces that should be taken into account while making a patient do deep breathing exercise. Fourth thing is that people have dropped dead after going for a jogging, after they think that they have completely recovered from COVID. So all these things should be considered while advising exercise to our patients. And what I do, I would tell you, and it is anecdotal, not based on any organized, I don't have any organized study, that I do not advise them any kind of exercises till the time we declare them recovered from COVID. That means they are COVID negative or 14 days have passed by, whichever is later. And after that, I write clearly on my prescription that please increase physical activity. That means they should frequently start walking. Those who are, housewives can start their household work immediately, but no rigorous exercises. Incentive spirometry is a good way of inflating the lung and also strengthening which is very readily available. But again, I tell them that don't test yourself. If your capacity is 100, please do only 80. None of the vigorous exercises would lead to better outcome. And I should think that pneumothorax is that we all pulmonologists are scared of. Besides this, some people hire physiotherapists for doing exercise. And it is anecdotal that one of the senior colleagues who had very severe COVID, and with difficulty he was saved after 1 month of ICU stay. So he hired a physiotherapist and he got a second infection from the physiotherapist. So that human touch should be avoided. Everything should be done virtually during this time. Whatever exercise you do, we do not know the outcome. Exercise is good for mental health, exercise is good for physical health, but it should done be gently, and incentive spirometry is the one that I would propose, and no vigorous and forceful exercise. That's but it's always anecdotal without any evidence. Thank you.
Thank you very much, Dr. Khilnani. Can we have the opinion of Dr. Prashant Mehta, especially in your critically ill oncology patients?
Hello. Yeah, thank you so much. Thank you so much, sir. And it was so enlightening and enriching to listen to Khilnani sir and Dr. Parthiv and all the faculty. So I would, I think, agree with Khilnani sir that we are not doing any rigorous, asking the patients to do any rigorous exercises when they are sick. But yes, post recovery in a guarded manner, we tell them to start moving a little more, and obviously not very rigorous exercises. But I think we have the kind of patients I have been treating have been pretty sick, so they are generally not in a position to engage in any strenuous activity. So, and yes, I agree with everybody that it takes many weeks, in fact, and many days to get to any good functional position for most patients, and definitely those who have had at least moderate to severe COVID. So those patients do have a lot of residual functional problems. Thank you, sir.
Perfect, Prashant. And lastly, Dr. Udip, what has been your experience about breathing and lungs in your COVID patients with cancer?
So, sir, good afternoon, good evening, everyone. So, sir, I think most of my patients who are cancer patients are invariably, many of them are on physical exercises, physiotherapy, as we feel that cancer itself needs an holistic care. And post-COVID, definitely, mental as well as physical well-being is as important for recovery. And I do feel that certain amount of physiotherapy, which involves the chest wall muscles as well as the limb muscles, improves the blood flow, improves the outcome tremendously in such patients. And I do agree with sir that aggressive exercises should be avoided in such patients.
Perfect. Thank you. I think that has been a wonderful discussion on breathing. Oh, Amish, can I now request you to take over and go ahead with your part?
Thank you, sir. Kashish, can I have my first slide?
Sure, sir.
Thank you so much, Dr. Mehta. This was something different. But at the same time, as Dr. Khilnani sir said, that you are always wondering what is the right amount of exercises. We'll not go into the details of that. In the attendees list, I don't see, in fact, I had prepared my slides based on the panelists. We'll try to change that. Would request Khilnani sir also and Tarini Sahu to chip in. There are two cases which I'm discussing today. First is 70-year-old female, cancer cervix with lung met since last 4.5 years, on multiple palliative chemo so far. Developed COVID 7 days back. Patient had approached one of the pulmonologist and COVID expert, and she was started on Medrol 32 mg per day with Apixaben 2.5 mg twice a day. Day 6 D-dimer was 1,332, that is 500 was the upper limit of the lab. C-reactive protein was 175, 10 being the upper limit. No CT scan thorax done as yet. Oxygen saturation was 92%. Admitted, patient was started on oxygen support plus remdesivir. Day 3 of admission, there was further deterioration in saturation. CT score was 12 by 25. X-ray before CT scan in the ward, there was no further deterioration as compared to baseline X-ray. But the D-dimer from 1,300 jumped to 3,400. C-reactive protein came down from 175 to 65. Now, these are the real values from the real patient. Question is that with CRP coming down and CT being in moderate and patient further deteriorating, should we change from Apixaben to low molecular weight heparin or increase the dose of Apixaben? This was the baseline. I'll come to my discussion. Next slide, please. Dr. Jiggy Divetia, the first question to you is, the first 3-4 questions are related only to D-dimer. Right from the first session of COVID and cancer, Dr. Tarini started this, but we have never reached a consensus as regards D-dimer. So Dr. Jiggy Divetia, pre-COVID era, in your ICU, when cancer patient is admitted with D-dimer, how do you approach this patient? High D-dimer, cancer in ICU.
So if you are talking of the non-COVID era, so
right, sir,
maybe 2 years back, then it depends on the situation in which the patient presents. So if he was otherwise, now this a similar patient who's had, I don't know, if he's had procedures, if he's had surgery, in that case, a D-dimer is virtually of no value. Okay, but if because if you had surgery or you had trauma or some procedure, like for example, patient like this, maybe let's say the CA cervix advanced had a PCN or something like that done, then D-dimer would not have much value. If the patient was otherwise well, then a normal D-dimer would sort of help to rule out a pulmonary embolism. Okay, but in general, if a cancer patient did have a high D-dimer, we would definitely look for thrombosis, and we would start anticoagulation on an empirical basis for him while we ruled out thrombosis, especially if the patient was breathless and getting hypoxia. In which case, and of course, we'll do an echo and look for right heart strain and that sort of thing. But I think we would definitely start him on some sort of anticoagulation. And in my book, the initial choice in someone like this with extensive lung mets could bleed into the lung and that sort of thing would actually be standard heparin rather than low molecular weight heparin. Firstly, because I could give it intravenously,
right,
load the patient up with heparin, start the workup for thrombosis and a pulmonary embolism. And then if it's negative, if it's CT angio or pulmonary angio is negative, then we would sort of de-escalate and just go to prophylactic anticoagulation.
I got your point, Dr. Jiggy. So basically, stage 4 CA cervix with this age and D-dimer high, you would start the patient on anticoagulation. Can we go to the next slide, please? We'll park that point here. We'll come back to that. Dr. Udip Maheshwari, next 3-4 slides are for you. And Dr. Tarini also, I would like to chip in here. So D-dimer as a potential clinical marker for predicting metastasis and progression in cancer has been known for many years. Next slide, please. So this is one of the slide where the increasing levels of D-dimer is associated with increasing levels of stages of cancer. This particular right-hand side, the chart is for breast cancer patients, while on left-hand side, if you see, as the stage of cancer increases, the D-dimer value increases. Next slide, please. Unfortunately, and Dr. Tarini and Dr. Udip, please note that in oncology, acute deep vein thrombosis, I don't see D-dimer anywhere coming in the picture. In the gamut of investigations, nowhere. Next slide, please. But there are many articles like this. I have put 3 articles here: high D-dimers with poor prognosis, predictive marker, and predicting metastasis also. Next slide, please. So Dr. Udip and Dr. Tarini, how significant D-dimer levels in cancer patient in a day-to-day OPD is? Dr. Udip.
Yeah, so Amish sir, the data looks promising, but how often do we do a D-dimer in metastatic cancers? As a prognostic marker, I don't think many of us are doing D-dimer as a prognostic marker unless there is indication for doing it. We don't, seem to follow D-dimer for cancer patients unless it is clinically indicated. Because, prognosis as a whole has to be looked at with multiple aspects in cancer patients. It cannot be only D-dimer per se or, solitary D-dimer levels which will tell you prognosis. And I don't think that becomes so important for me in my clinical management or decision making.
Right, great. Tarini.
Two things. First of all, I think in the first case which you told, in a non-COVID era, any abdominal malignancy, advanced especially, would require a LMW prophylaxis. That's the recommendation for all societies put together. Point number 1. Number 2, do we follow ever D-dimer? Before this thing happened in normal cancer treatment, it is no. So I have never done that. I never used to do that. Last point is, can we just look at D-dimer and start prognosticating patients? I don't think we would need a good multivariate analysis to look into what is the significance of that single factor. I totally agree there could be a lot of contributing factor which could be there. But yes, in advanced cancer, even in non-COVID, many of us do not used to do that, but all ASCO guidelines, including a lot of other guidelines, do accept that in at least abdominal malignancies, if admitted for any reason, should require a prophylaxis.
Right. So Tarini, you are absolutely right. We are talking of D-dimer here, and I hear from both the oncologists that D-dimer alone has got no value in oncology for any decision making. Next slide, please. So Dr. Prashant, you have been seeing many of non-oncology cases also. So in non-oncology patients, COVID and D-dimer, do you think that it is predictive, prognostic, or therapeutic value? Because American Association of Hematology, or ASH guidelines, and thrombosis guidelines, they say that D-dimer alone should never be taken for taking any decision in the clinical management of COVID patient. Prashant.
Yeah, so I absolutely agree with you, sir. So D-dimer alone, first thing, in mild cases, D-dimer should not be done. It is not indicated. Patients who are admitted with us, who are hospitalized, for those patients we are doing a D-dimer. That's the practice. And for patients who have more than 2 times elevated D-dimer, those are the ones, and the hypoxic patients who are sick, they have been put on low molecular weight heparin, and that's the standard practice we have been following. And there is some data to that effect. I think you will be quoting that from the remap cap and recovery probably. So,
Dr. Parthiv Mehta, can I conclude that D-dimer alone during COVID era or pre or post COVID era should never be taken as an indicator of any anticoagulation in the clinical practice?
Agreed. I'm seconding what Dr. Prashant has said. Simply basis on the numbers of D-dimer, without taking into consideration of requirement of oxygen, status of oxygenation of the patient, oral, even not only status of oxygen, I would try to believe more in ABG analysis, which talks about the PaO2 levels also. And then only seconded with radiological investigation, which talks about more infiltrations. And then we talk about complete a list which talks about D-dimer and its value in such a given patient. But Dr. Divetia is there. He should be also able to guide us more into this.
Right. We are coming to Dr. Jigi again. Can I have the next slide, please? Dr. Nandita has joined us. Dr. Nandita.
Yes, sorry, yes.
So, we are on the last slide and the last question only on D-dimer. We are not talking of anything else. In UK, when do you use D-dimer, or if it is elevated in absence of any other clinical findings, do you really bother about D-dimer values?
No, I think clinical findings are very important. You have to, each patient has to be looked at. And I agree with all the other members as well that not just in the first wave, people were more concentrating on the D-dimers, but as more and more evidence came into the, we have to look at the patient. We have to look at the oxygenation levels and things like that. And then we decide. So we have a protocol. Sorry, I forgot to send it to you. I'll send it to you what we have our guidelines as to.
No problem. Dr. Nandita,
yes,
more than 6 times the value of D-dimer is 46 to 50% of these patients had some form of DVT or pulmonary embolism in meta-analysis after meta-analysis. But still the guidelines say that D-dimer alone should not be used as a parameter. Isn't this a little paradox?
Yeah, it is. But as I said, our experience and the evidence show that it is, you have to take it even if it is higher. So we always give patients thromboprophylaxis for all the admitted patients. But whether to go on to...
We are not talking of admitted. We'll come to that. Only D-dimer.
Oh, sorry. I missed the first part. So no, not just D-dimers.
Not just D-dimer. Sorry. Next slide, please. Okay. Now we are coming to anticoagulation in COVID. We have talked about D-dimer. Next slide, please. So, what I have highlighted that in a non-hospitalized patients with COVID-19, anticoagulants and antiplatelet therapy should not be initiated in prevention of venous thromboembolism. And this is an NIH guidelines, just February 2021. Next slide, please. Dr. Parthiv Mehta, but before that, can I request Dr. Khilnani sir to answer this question in case if he is still there with us? Sir, in a non-hospitalized patients with COVID, when will you start anticoagulation? And if yes, what dose, which drug, and how much is the duration? In a non-hospitalized patient, non-cancer patient, sir.
I get your question very rightly, Amish, and I knew you would ask me intricate question. That's why I said I don't want to be there. So anyway, but I would like to be there as an audience. But anyway, I must tell you what I do. The D-dimer test in COVID has been a big confusion maker for us. because we always get it done along with CRP, CBC, ferritin, and IL-6. And D-dimer, more often than not, even in mild to moderate cases, either it is marginally raised and sometimes markedly raised. The trouble comes when the person does not have much of pneumonia, does not have much of hypoxemia, his oxygenation is normal, but D-dimer is marginally raised or 2 times the upper limit of normal. The question comes whether you should start him on some kind of anticoagulant or antiplatelet therapy or ecosprin or clopidogrel or now easily available newer oral anticoagulants. My answer would be no. I have a reason for saying that the D-dimer in COVID is a marker of inflammation, is not a marker of thrombosis. So therefore, my anticoagulation in these patients, whether low molecular weight heparin or newer oral anticoagulant, Pixamon or whatever, starts only when a person is requiring steroids for the treatment. And that part we have discussed in our last meeting. Whenever a patient qualifies for receiving steroids, then only my thought process begins whether this patient requires anticoagulation and where D-dimer doesn't help. For example, if the person has got severe inflammation and severe pneumonia and CRP is high and D-dimer is normal, even then I'm going a little ahead of your question, but coming back to your question, in the outpatient, I do not give them anticoagulation. Thank you.
Dr. Parthiv, you have anything to add to what Dr. Khilnani sir has said, and just what Dr. Khilnani sir mentioned about D-dimer being a marker of inflammation? That reminds me of the first NEJM paper in 2020 where 7 autopsy findings were given and based on which the entire gamut of COVID treatment has started. Do you agree that endothelitis or intravascular hemorrhage or clotting is one of the main cause of COVID pneumonia?
I would definitely. I have been always following Khilnani sir as one of our gurus and sort of stalwarts. Just follow blindly what he says is the thumb rule, and same has happened. Yes, I obviously am to second what sir has said. One smaller point here is sometimes it has been said that D-dimer can be a marker of venous stasis in morbidly obese patients who are not much mobilized, those who are static in the bed, and they are not hydrated well. Either patient has a bad diarrhea, patient has a dehydration and not drinking water well, and on third or fourth or fifth day, when patient has doubling of D-dimer, the only area wherein probably I would think of, though other inflammatory markers have not gone up, but if there is a doubling of D-dimer and patient complains of chest discomfort, when the patient is still in outpatient at home or in home isolation care and tachycardia arises, that is the probably time that yes, we have to think over to get into a picture wherein we would like to stop the progression of that probably thrombosic process, or probably will try to help them out with something which retards the progression of such an event which can lead to a catastrophe later on. That is only an add-on or a smaller change. Otherwise,
so rapidly rising D-dimer, you would be worried and you would think of anticoagulation in a non-hospitalized patients also. Next slide, please. So again, Dr. Tarini and Dr. Udip, 67-year-old female, low-grade non-Hodgkin's lymphoma on maintenance rituximab, COVID positive 23 days after last dose of rituximab. In a mild category, according to ICMR, fever for 5 days. Inflammatory markers, again, D-dimer 3000 and C-reactive protein is 26. Would you give anticoagulation in this patient if patient does not require admission, thinking that rituximab will go on and will keep reducing the humoral immunity? Tarini first and Udip later.
For this case, no, I would not. I will probably repeat the markers after 3 days and clinically follow.
And after 3 days, only D-dimer is 3000 to 4000.
If clinically you're telling it's mild and expect it to be mildly symptomatic and no respiratory symptoms, I will keep a close watch.
Excellent. Dr. Udip, would you agree?
Yes, I would tend to agree. Just only thing that I would want to add is that 2 risk factors, one is lymphoma, one is age. So these 2 risk factors will add to the hypercoagulable state in such patients. We need to be extremely careful in such patients wherein if a rapid rise of D-dimer is...
At this point of time, Udip, will you give anticoagulation also?
No.
You will not give. Next slide, please. And Udip, stay on this. Before that, Dr. Prashant. Dr. Prashant, in non-hospitalized COVID patients with cancer, Dr. Khilnani sir talked about not cancer. With cancer, non-hospitalized COVID patients, when would you start anticoagulation?
So, if it is a mild case, again, I would not start unless there is a indication with regard to the cancer, like a gynecological advanced malignancy, which is in itself a thrombotic state, or somebody who is on procoagulant drug already. That is where I would do. But in a mild case, in a non-hospitalized, I would not.
Okay. So whether cancer or no cancer, except there is any major risk, abdominal or pelvic malignancy,
yes. So
things remain exactly the same, right?
Apart from the COVID, if there is some indication of giving anticoagulation, I would do.
Dr. Mehta, I assume that you would agree on that point.
Oh yes, for sure. What we have been doing in mild patients, 6-minute walk. I think Khilnani sir would also be, putting a more light onto that. 6-minute walk and drop in the saturation. That becomes an area to be watchfully handled. And that if the patient is having fever, throwing fever and becoming more symptomatic, that would be the time with rise in D-dimer. Yes, we should think over for.
So Dr. Khilnani sir very clearly mentioned, and I think that is the take-home message, is that anytime when the patient requires oxygen with high D-dimer, patient, irrespective of whatever is the lab value, should be considered for anticoagulation in non-hospitalized patients. Next slide, please. So, Udip, this patient of CA cervix, which I discussed first, was started on apixaben and Medrol before even getting admitted. Would you agree a stage 4 CA cervix with lung metastasis, apixaben started rightly, yes or no?
So, yes, rightly, yes.
You would agree. Tarini, would you agree?
Patient, if on the OPD basis, does not require any indication, and is it mild or moderate? It is, or that saturation 92 since day one?
Saturation 92%. There's a last CT scan showed lymphangitis carcinomatosis, so we don't know the falling values.
So what I follow is if a patient of CS cervix advanced on my OPD on discharge, I never give her oral anticoagulant till the patient admitted.
Excellent. I think this is what I am hearing consistently. The reason of raising this point, in the next slide, please, because consistently I am seeing, next slide, please. Consistently I see in non-hospitalized patient, every patient at least is on ecosprin in the city of Delhi, and some of them are on apixaben also. Next slide, please. Okay, we can move to the next slide. We have covered this point. Parikh sir, can I request you, because it's a very important point, in a non-hospitalized COVID patient, whether cancer or no cancer, how would you summarize D-dimer value and anticoagulation?
So I think Nandita has rightly put it that in the first wave, a lot of attention was given to D-dimer as a marker for management of COVID positive patients. And in the second wave, they are feeling that it is not so important. So I think that is the message that I would want the audience to go back with, that D-dimer by itself should not dictate the way that we are treating patients of cancer who have COVID.
Excellent, sir. And in a non-hospitalized patient, as Dr. Khilnani sir rightly mentioned, and Parthiv sir also agreed, anytime when the patient requires oxygen, think of anticoagulation irrespective of D-dimer value. Next slide, please. Now, coming to hospitalized patient with COVID, Dr. Divetia and Dr. Nandita, let us start with ICU. Every patient in ICU with COVID, with or without cancer, should be anticoagulated, true or false? And I want to know the dosages of anticoagulation and your evidence for that answer, because this is extremely important. I would again repeat, patient is admitted in ICU with severe COVID. Should they, all of them be anticoagulated? If yes, what is the drug and what is the dose?
So
Dr. Divetia and Dr. Nandita, yes, you can start.
Sorry. In our ICU, if the patient is, if it's mild, Then we give prophylactic deltaparin. We don't give oral anticoagulation. And if it is, intermediate, if it's not for therapeutic anticoagulation, we give the intermediate dose. And again, I can read you out the intermediate dose. I've got my card in front of me. In patients who are less than 46 kg, we give 2,500 units BD or 5,000 units once a day of deltaparin. 46 to 100 kg, 5,000 units BD or 10,000 units OD deltaparin. 101 to 150 kg, 7,500 BD or 15,000 OD, and greater than 150, it is 18,000. If thrombocytopenic, you continue anticoagulation provided platelets are greater than 30, unless clinical signs of hemorrhage or hit. So that's what we do in our hospital.
If I understand correctly, intermediate dose,
yes,
if patients admitted in ICU,
yes,
COVID.
Yes.
If any patient admitted in ICU with COVID, we would consider them as severe COVID. Is that correct?
Yes. So in our critical care, if it was slightly different this time, most of our patients were ventilated in the first wave. This time there were quite a few they were severe COVID on very high oxygen requirements for NIV or for on CPAP. That's what we did.
So there were non-ventilated also patients who were there in the ICU, even though they qualified for severe COVID.
Yes, there were some, because in fact there were quite a few this time. Yeah.
Dr. Jiggy, do you follow the same dose of deltaparin or enoxaparin? Let's talk of intermediate dose. Dr. Jiggy?
Yeah, so when we started off in the first wave, we were actually using the intermediate. And now let me just be clear that we are saying anticoagulation, we are talking of thromboprophylaxis.
Prophylaxis, yes.
We are talking of a prophylactic dose of any of the low molecular weight.
I'm asking you, what dose do you use? What drug do you use? Whether it is prophylaxis or therapeutic is a separate thing.
So, no. So it's prophylaxis. It's not therapeutic.
Right. Okay.
So now the question is whether you use standard dose prophylaxis or an intermediate dose prophylaxis. So standard dose for us for most of our patients is 0.4 milligrams OD of enoxaparin. Okay. And intermediate dose would be either 0.6 OD or 0.4 BD.
Right, sir.
Now, in the beginning, we were using intermediate dose because I think that's what was being extensively used even in the UK and many other places. But I think now we've got a trial, we've got data from a multiple platform trial, which includes the REMAP CAP and a couple of other trials, which says that one therapeutic anticoagulation, therapeutic, that's 0.6 BD, is now no better than prophylactic and maybe higher in risk of bleeding. So therapeutic anticoagulation, even in patients who got severe COVID who are ventilated, is not indicated unless the patient has thrombosis, either a pulmonary embolism or venous thrombosis or arterial thrombosis or something, then that's different. But just because he's got severe COVID and he's on a ventilator doesn't mean he should get therapeutic high dose anticoagulation. Then the question is whether we should give intermediate dose prophylaxis or standard dose prophylaxis. And we were either way, but I think very recently in the last couple of weeks or maybe a month, we've got the Inspiration trial which has come out and which shows that there is no difference in outcome whether you give intermediate dose prophylaxis or standard dose prophylaxis. So I guess the answer would be stick to standard dose prophylaxis in ICU.
So
unless
standard dose prophylaxis of 0.4 mg per kg of enoxaparin, or what Dr. Nandita talked about intermediate dose, but you do not agree that intermediate dose of either enoxaparin or deltaparin should be used in hospitalized ICU patients with COVID. Am I reading, sir, you correctly?
So I'm not sure whether intermediate dose, there's only one trial which shows that it is no better than standard dose.
Let's look at these two publications, Dr. Jiggy, and then maybe Dr. Nandita, I can come to you.
Yeah.
Can I have next slide, please? So next slide, please. This is in spite of prophylaxis, patients, as good as 30% of patients in ICU get thrombosis or VTE or PE. Next slide, please. So these are the two publications which Dr. Jiggy were talking about, the Inspiration randomized control trial, but that is fully from Iran. And there is something new concept for which I think Parikh sir should once take a lecture for us. that this is something that 3 different trials on a common platform, and they come together to answer a common question. That is what I have understood. Next slide, please. So in the first trial, which was published in JAMA, March 18, 2021, inspiration trial from Iran, what they found that in ICU patients admitted with COVID, intermediate dose prophylaxis is as good as standard dose prophylaxis. So this is what Dr. Jiggy sir was talking about. Next slide, please. Now here comes a little paradox about it. ATAC trial, REMAP-CAP trial, and Active 4A trial together again address the same, but in 2 different populations. One in moderate COVID patients and one is severe COVID patients. Next slide, please. And what they concluded was that in moderate COVID patients, hospitalized but not ICU patients, therapeutic dose anticoagulation, not prophylaxis, therapeutic dose anticoagulation did better. Next slide, please. While in severe cases who were admitted in ICU, therapeutic dose of anticoagulation did not do well. In fact, it was inferior to thromboprophylaxis. So Dr. Jiggy, again for take-home message, let me see, enoxaparin is being used in India very commonly. Enoxaparin 0.4 mg per kg is the standard prophylactic dose, and enoxaparin 0.4 mg per kg twice a day is a standard therapeutic dose.
1 milligram per kg.
Or 1 milligram per kilogram is a standard therapeutic dose. So according to this REMAP-CAP and Active 4A and the third trial, if the patient is having moderate COVID, you give 1 mg per kg per day instead of 0.4 mg per kg per day. Am I reading this trial correctly, Jiggy sir? Because this is very confusion, and I would want after you, Dr. Prashant Mehta, to address his concerns, because he and I have discussed this issue quite a lot. Jiggy sir.
Okay, so let me tell you, the one published paper, okay, at least in a preprint, is the ICU patient study, okay, which shows that you should not be giving high dose therapeutic anticoagulation, and standard dose anticoagulation is good enough. Okay, I think that is definite. So, and whether based on the recent inspiration study, you're okay even with the standard prophylactic dose of 0.4 milligrams of Clexane. Intermediate dose, this is the one trial which says that intermediate dose is no better than a standard therapeutic dose. Okay. Now, as far as the moderate COVID is concerned, okay, and again, this is like you said, it's a multi-platform, they've got together and they've got this, but this data is not yet published. It's not even a preprint. There's some data which they've put on the website. It seems to suggest that in moderate COVID, if you give therapeutic anticoagulation, it improves outcome. And the logic, if this does turn out to be true, and if the data sort of stands up to scrutiny, the logic is that when the patient is already in ICU, you've already had extensive damage from whatever your thrombosis or may have caused, and therefore anticoagulating at that stage doesn't help. Whereas in moderate COVID, if you give it, you might be able to prevent some of the damage due to thrombosis, intravascular or microthrombi or whatever that may be developing. And maybe that's why it may be beneficial. But I think as of today, it is a little premature to say that in moderate COVID, we should give therapeutic anticoagulation. It may
Khilnani
become...
Sir, yeah, Prashant, I'll come to you. If Khilnani sir and Dr. Parthiv Mehta, both of them can comment on this trials which have not been published, which has not been peer reviewed as yet, Dr. Jiggy said, but it is an absolute paradox. In moderate patients who do not require ICU, you treat them with a full dose of anticoagulation as if they have got VTE. While the patient goes to the ICU, you give them prophylactic dose. Dr. Khilnani sir, then Dr. Parthiv Mehta.
So first a submission that Dr. Divetia has been my role model in critical care. So there's nothing beyond Dr. Divetia when it comes to critical care. I'm not saying, ye dil se, heart se, bilkul. He is one of the
but you should not youngest, be to the reverse.
Youngest president of ISCCM, and huge respect for him. And he has very rightly said, where do you draw the line? What is moderate and what is severe? So you should not go by one study which is not yet published that in the moderate you give therapeutic dosages. I'll just summarize in one line. If I was to treat a patient whether moderate or severe, I would go by standard dose and not go to because I have seen in my practice several cases of bleeding. And I don't know how many patients we have saved by giving heparin, but surely we have caused bleeding in so many patients. So therefore, for me, the dose is standard dose. Thank you.
So Dr. Khilnani sir, if I have to sum up what you are trying to say, that whether it is moderate or severe, if the patient does not have established venous thromboembolism, you would give standard dose prophylaxis, that is 0.4 mg per kg of enoxaparin. Is that
absolutely
correct?
Absolutely.
Right.
No confusion.
Dr. Parthiv sir, do you have something else to say?
Now, we have been. I'm coming on to it. The moderately severe cases, when they enter and then when they are still in the rise of their all the markers, rise in the requirement of oxygenation, and when we find that these lungs are typically dry with not much of severe infiltrates, means they are not into an alveolytic phase, they are more into a typical phenotype, which is more of a thrombotic phenotype. May it be a microcapillary thrombi or may it be a thrombotic phenotype. They are the one typical wherein we would like to use a therapeutic dose. But those who have had deep shadows, those who have had great alveolytic, typical profile wherein we are convinced that it is not, the D dimers are also not rising pro rata compared to the rise in the other markers and the requirement of oxygen, wherein only a standard dose is, that is what you have been used. This is once again derived out of our own understanding of the diseases. We have had more instances compared to the standard dose in terms of bleeding, but it has not led to a life-threatening bleeding. But yes, I agree with sir. Bleeding has been one of the issues wherein we have used higher than the standard or a therapeutic dose.
Right. So Parthiv sir, where do you use higher than standard prophylactic dose?
It is only therapeutic dose where the patient is proven to be in higher oxygen requirement, rise in oxygen requirement is more, and the D dimers have doubled within 48 hours. And at the same time, we are convinced about this being a thrombotic predominant event. That is where we are using a higher than the standard dose. Otherwise, all standard dose prophylaxis.
So Prashant Mehta, Prashant, you also have been, you are an oncologist, but you are also looking after ICU in non-oncology and oncology.
So I have been posted out 2 days back. So
I'm little confused. I'm
in any case,
confused. Dr. Khilnani sir and Dr. Divetia sir are both of the opinion that whether moderate or severe, if the patient does not have VTE, you give a standard dose prophylactic of anticoagulation, that is enoxaparin 0.4 mg per kg. Dr. Parthiv Mehta is saying that yes, he would follow the same, but if there is a rising trend of D dimer with the clinical situation worse, he may use standard dose of the treatment dose of enoxaparin, that is 1 milligram per kilogram per day. Dr. Prashant, what do you do in your practice, and do you agree with all the three stalwarts who have said?
So I agree with most of what everybody has said, but I have not used therapeutic anticoagulation for any patient. I've used intermediate dose, max intermediate doses. So we have not been using therapeutic doses as a prophylaxis for anybody unless you have proven thrombosis.
Okay. So what I hear from all the panelists, and Dr. Tarini, you also have been treating COVID patients in your hospital, especially in oncology COVID patients. Do you agree that if patient does not have VTE, the therapeutic dose of anticoagulation, that is 1 milligram per kilogram, should not be used?
I practice what has been told. I use a prophylactic dose till I have a proven thrombosis.
Okay, excellent. So we all have reached a consensus here. Next slide, please.
I just have one question on the doses. Like, correct me if I'm wrong. The intermediate, or the prophylactic doses up till 0.5 mg per kg twice a day of enoxaparin.
Oh, so that is 0.6 mg per kg per day in the trial. What they have taken as an
in the study you're saying, but
in a patient who are less than 100 kg and patients who are more than 100 kg, they have gone up to twice a day. Prashant.
Okay.
So it is more of the morbidly obese patient. You can increase the dose of intermediate dose of prophylaxis. Can I have the next slide, please? I have 3-4 minutes left, and this is exactly what the trial said. Next slide, please. Okay, Dr. Divetia and Dr. Khilnani and Dr. Parthiv have agreed that this paradox is too early for us to believe. Unless and until this paper comes in publication after peer review, we should not change our practice. Next slide, please. ICMR guideline does not mention too much about these things, but it mentions that every patient hospitalized with COVID should receive anticoagulation, whether they are in the ward or they are in the ICU, and majority of our panelists agree with the same. Next slide, please. Dr. Khilnani sir, I see you topmost on my, and you are very, we love to hear you. Apixaben or rivaroxaben has been not talked so much about COVID, but every patient, either before admission or after admission, are put on these two anticoagulants, direct anticoagulants. What is your take on when should we use apixaben and or rivaroxaben?
So, as whatever little knowledge I have about this, these newer oral anticoagulants, they are as good as heparin, low molecular or otherwise, as far as the treatment of venous thromboembolism is concerned. They have been overused during COVID because of ease of administration. So, I'm being a little prophetic, but it's not evidence-based. But in our practice, we do not give them in patients who are inpatient because we feel that low molecular heparin is better to use and better to easily control. But when they are discharged, and if they have had moderately severe disease, then we take a call on sending them on newer oral anticoagulant, nothing to choose between apixaban or rivaroxaban. I do not use dabigatran for obvious reasons, being lesser safety, and we give it for a period of 10 to 15 days. And then again, I would say that the D-dimer is most unpredictable and unreliable parameter for monitoring this because of the simple reason that one day you will have a reading of 400, next day you get 5,000, you repeat it, comes to, so this we have seen it, and one of the reasons which laboratory people are citing is that if the sample is lying on the table for 2-3 hours, the D-dimer escalates. So, so summarizing it, that in moderately severe cases, we give this anticoagulation by apixaban or rivaroxaban for a period of 10 days, and we do repeat markers. And again, I'm saying that I rely more on CRP than D-dimer, even for continuing anticoagulation. Thank you.
Excellent, sir. Dr. Nandita, the last comment from you. After that, can I request Dr. Tarini to summarize about anticoagulation in hospitalized patients, and then Dr. Parthiv, whether Dr. Tarini has understood it well or not. First, Dr. Nandita.
Can I ask a small question to the panelists? We know the oral anticoagulants, the DOACs, and people are giving it with remdesivir, and there is a reaction, isn't it? Cytochrome P3A4 metabolism is affected, and therefore you then have more chances of developing if you have any thrombosis. So is it yes to give them? We don't give it. I'm just saying, just putting an idea for that there is a reaction. Yeah, we send our patients who have been in critical care on DOACs. We send them on rivaroxaban, but I don't think there's any difference between the two when they go home for 4 weeks, if they have been in critical care. That is, if they have not had DVT or PE. But if they've had DVT or PE, then whatever is the treatment for DVT and PE should be continued. But these are the ones who
treatment of established VT has got no confusion.
Absolutely. So that's what
world people use that. So we are talking of this correct, and thank you, Dr. Nandita, for that. Dr. Tarini, can you sum up hospitalized patient anticoagulation? Yes.
Yeah, I'll sum it up and then ask a question to the expert. Such a panel you'll never get. Okay, so first thing is that what we could take home is D-dimer is a very unpredictable marker. and we would not be using it as a standalone marker to decide on things. So in COVID, it has been basically a clinical parameters which make most of the decisions. The inflammatory markers would help us, but would not be the only one which will guide us. Number two, in the OPD patients, especially with mild COVID patients, irrespective of the risk factors, most of the take home is that people would be not giving any prophylaxis. But once the patient gets admitted for moderate to severe or even the ICU, if as per the things, most of the panel feels that you would be giving a prophylaxis, and that prophylactic will be at the prophylactic dose. And the controversy regarding the therapeutic versus prophylactic in the moderate versus severe, where the moderate there was some evidence, has not been in the most of the panel has not been in support of that, and in want of further evidence. So at this point, for hospitalized patient, it will be a prophylactic dose of low molecular weight heparin, anyone which you use. And at discharge, for a hospitalized patient, you would be using at a prophylactic dose of apixaban, let's say 2.5 twice a day for 15 days. That is what the take home would be. And that's what I got from the whole panel. And the last, which I want to ask this panel is, so is it that the panel is telling that D-dimer should be abandoned and should not be used, and it just adds on to the cost because so unpredictable does not help us anyway? Number two, is there any value of D-dimer, let's say 5 times, 10 times of the upper limit of normal in a rightfully done in the good lab, where people would go for a pulmonary angio? Because you rightly pointed out that in the post-mortem, people have found 40 to 60% patients having embolism, with higher elevated D-dimer. So is it that this has no indication? The few of the data which is there in the extremely highly elevated D-dimer, significantly high pulmonary angio is an indication? Or where do people do pulmonary angio once they're clinically symptomatic for embolism? So that's the only thing I have a confusion.
So Parikh sir, we have crossed our 2 more minutes. Can we take this Tarini's question and can we ask?
Yeah, I will finish.
Please go ahead. Important.
Perfect. Right. So we start with Dr. Parthiv Mehta sir. Sir, can you answer both the questions?
The take home was okay, Amish sir. As per your good recommendation, can it be passed as a good okay pass?
Tarini, that we will speak offline.
Okay.
Let's first answer. Dr. Parthiv is with us still?
Yeah, I'm here.
Okay. Dr. Parthiv, the first question is, should we abandon D-dimer?
No. We should rightfully use D-dimer. As Khilnani sir has said, even Dr. Divetia said, we have to use it as a combo with other clinical parameter, even using other indirect markers, and try to put it together as a part of whole investigation profile, which will help us to understand the behavior of the disease. Yes, if oxygenation is not improving well, and if there is a jump, if there is a definite, I would also try to put in something like even getting an echocardiogram done, which talks about the RA-RV dilatation and rise in RV pressures with rise in D-dimer, sudden fall in oxygenation and RA-RV dilated. Probably I would try to use this as a marker of probably wherein I would like to go for a CT pulmonary angio and try to see whether there is a significant thrombus which has come in as an acute event, whether I would like to go for a therapeutic thrombolytic therapy or not. That is what is the use probably in a critical care in COVID with D-dimer. That is what probably I try to put in.
So Dr. Parthiv, you have answered the second question of Dr. Tarini, is that if there is an elevated D-dimer in an ICU patient and there is a rising trend, you would advocate a CT pulmonary angio to rule out early pulmonary embolism. Is that the correct thing which I'm hearing?
Yes.
No, I think sir told that if the patient is clinically fitting into the criteria of pulmonary embolism, with the echo suggesting towards that, with the parameter of D-dimer increasing, then only we will go for a CT angio. That's what.
Thank you so much. So I am also confused, Jiggy sir and Dr. Nandita. I feel after hearing all these things and after hearing all the experts, D-dimer should be abandoned. Apart from predictive or prognostic value, it has got nothing else. Dr. Jiggy and Dr. Nandita.
So Amish, I would refrain from making such sweeping, strong statements that this should be abandoned or that this is useless or it should be confined to the dustbin. It has a place. So in the sort of situation that Dr. Parthiv was describing, you've got a patient who was maybe at home and he's recovered, but now he comes on follow-up with a little bit of breathlessness and a little hypoxic, say, 2 weeks down the line, and then you do a D-dimer, if it is high, your antennae should be up that, this could well be evolving pulmonary embolism, right? So, and you need to work up the patient, whether you do a simple echo or whether you do, or then you go ahead and do a pulmonary CT angio, that's a different issue. But just a high D-dimer without any clinical problems, I guess it's okay, right? But maybe in some patient, it should gear up your antennae to say that maybe there is something going on if it's high and rising in the absence of inflammation and all those sorts of things. So I don't think it has no value, but it has limited value and certainly not as much value as some people attribute to it. That's for sure.
Dr. Nandita.
The other point, Amish, if I may.
Sorry, Jiki sir, you continue, please.
If you're talking of, in a cancer patient, if you're talking of continuing anticoagulate or thromboprophylaxis beyond the hospitalized phase, say for 4 weeks or 6 weeks or whatever it may be, there may be some value to considering a low molecular weight heparin from the oncological point of view, rather than, we know that warfarin is inferior to low molecular weight heparin. We are not, at least I am not sure of the data of NOACs versus low molecular weight as far as cancer is concerned, but definitely I do know that low molecular weight heparins are preferred in cancer patients. So maybe that's one consideration you may have in some of your cancer patients.
Thank you, sir. Thank you so much for such a nice, wonderful comment. Dr. Nandita, would you like to answer both Dr. Tarini's questions?
No, I'm completely in agreement with Dr. Divetia, because I just feel just on its own, you should not say everything is, you have to clinically correlate. I've said that before as well. And anything on its own is not enough. So if there is sudden rise and if the patient is showing clinical signs and symptoms, then yes, we will go for, if possible, CTPA or echo or something. If the patient we can't take to the lab, to get a CTPA down. So we have to do it clinically and based on our clinical judgment. However, as I said, I'm not going to rule out D-dimers completely, as I completely agree with Dr. Divetia. It'll be too naive of me. Sorry.
Tarini, I hope, I think, right from day one, we were searching for these answers. Some of the answers we have got. And with that, can I request, if anybody else has any comments, otherwise, can I request Parikh sir to conclude the session?
Thank you very much, Amish. Thank you very much, Parthiv Mehta sir. Thank you all the panelists, as well as people who were roped into giving their comments, even though their name was not officially as a panelist. So Nandita and Dr. Kilnani, thank you very much as well. And as usual, our next meeting is in 2 days on Thursday. So see you then. Till that time, please stay safe and good night, everybody.